All right, so what is protection? It's the primary and secondary defense mechanisms, which is the immune system, skin, hepatic, hematologic, and renal systems all working together to maintain homeostasis and responses to real or perceived injury or infection. These are just some terms to know that I will be talking about a little bit later on, so just so that you know these terms and the terms on the next slide when I get to talking about them later on. So when talking about cancer and treatments and talking about chemo and where it hits, it's important to know the cell cycles, so go back and refresh on that. So, your cycle begins, the cell grows, it decides whether or not it wants to continue growing. If it does, it replicates that DNA and the cell prepares to divide. Mitosis, that cell goes through that prophase, metaphase, anaphase. It starts dividing, going into the telophase, and then it's the cytokinesis. So these are kind of important to know when you're really getting into the medications and everything for treating cancers and where it hits on this cell, on the cell cycle. All right, cancer. I want you to take a minute and think about, what do you think of when you hear the word cancer? Just thinking about that for a minute. Do you think of anything positive? Most people think death sentence, pain, miserable, vomiting, hospitals. None of that's positive. Cancer doesn't discriminate. It can hit anybody, rich or poor. Doesn't matter the race. Doesn't matter how good you are, how much you believe. Doesn't matter about anything. It can affect anyone at any time. So it's important for nurses to think about your perception of cancer. And you must be prepared to support our patients and family members with physical, emotional, social, cultural, financial, and spiritual challenges. So all of that combined into one patient with family members. So it's a lot to deal with in oncology. These are the main categories of cancer. You have your carcinomas, which are the most common type of cancer. They are formed by epithelial cells, which are the cells that cover the inside and outside surfaces of the body. Carcinomas that begin in different epithelial cell types have specific names, like adenocarcinoma. That's a cancer that forms in epithelial cells that produce fluids or mucus. Tissues with this type of epithelial cell are sometimes called glandular tissues. Most cancers of the breast, colon, and prostate are adenocarcinomas. You have your basal cell carcinomas. That's a cancer that begins in the lower or basal layer of the epidermis, which is our outer layer of skin. You have your squamous cell carcinomas, a cancer that forms in squamous cells, which are epithelial cells that lie just beneath the outer surface of the skin. Squamous cells also line many other organs like the stomach, intestines, lungs, bladder, and kidneys. Squamous cells, if you remember from your biology class, look flat, kind of like fish scales, and when viewed under a microscope, the squamous cell carcinomas are sometimes called epidermoid carcinomas. Transitional cell carcinomas, cancer that forms in a type of epithelial tissue called transitional epithelium or urothelium. This is made up of many layers of epithelial cells that can get bigger and smaller, found in the linings of the bladder, ureters, part of the kidneys, and a few other organs. Some cancers of the bladder, ureters, and kidneys are transitional cell carcinomas. Your sarcomas. Our osteosarcoma is the most common cancer of the bone. The most common types of soft tissue carcinoma are leiomyosarcoma, Kaposi sarcoma, malignant fibrous histiocytoma, liposarcomas, and dermatofibrosarcoma protuberans. Then you have your leukemia, which is in the blood or bone marrow. You have your lymphomas in the immune system. Multiple myeloma is a cancer that begins in the plasma cells, another type of immune cell. The abnormal plasma cells called myeloma cells build up in the bone marrow and form tumors in bones all through the body. Multiple myeloma is also called plasma cell myeloma and collar disease. Then you have your CNS cancers, which affect your brain and spinal cord. So cancer is a disease process that begins when abnormal cells are transformed by a genetic mutation of the cellular DNA. Cancer cells usually have a larger nucleus with an irregular shape. Malignant cells' nuclei are larger and more numerous because of increased RNA synthesis. Cell division occurs more rapidly in malignant cells. Cancer is the number 2 cause of death behind cardiovascular disease. These are the top cancers among men and women, lung being the number 1. For men, number 2 is prostate, women is breast cancer, and then it goes colorectal and melanoma, the next 2 after that. During the lifespan, cells undergo periods of rapid or proliferative growth, which needs to be distinguished between malignant growth activity. So we can see hyperplasia, which is an increase in number of tissue cells, metaplasia, that conversion of normal tissue cells to abnormal tissue cells, dysplasia, which is the change in cell size, shape, or organization, anaplasia, that presence of undifferentiated or poorly developed cells, neoplasia, abnormal growth of new type of cell, which is your tumor growth. So here we see characteristics of benign and malignant tumors. So there are benign tumors, which are non-cancerous, and then you have your malignant tumors, which are cancerous. So with looking at the cells, the cell characteristics, you'll see that benign cells pretty much resemble the normal cells of the tissue, whereas your malignant cells are undifferentiated and bear little to no resemblance to the normal cells of the tissue from which they arose. The mode of growth, your benign tumor grows by expansion and does not infiltrate surrounding tissues, and they're usually encapsulated. Your malignant tumors grow at the periphery and overcomes contact inhibition to invade and infiltrate surrounding tissues. Your rate of growth, benign tumors are usually slow growing. Your malignant tumors are variable and depends on the level of differentiation. The more anaplastic the tumor, the faster its growth. Benign tumors usually do not spread. Malignant tumors gain access to the blood and lymphatic channels and metastasize to other areas of the body. General effects, benign is usually localized, that does not cause generalized effects unless its location interferes with vital functions. Malignant tumors often cause generalized effects such as anemia, weakness, systemic inflammation, weight loss. Tissue destruction, benign tumors usually do not cause tissue damage unless its location interferes with blood flow. Malignant tumors often cause extensive tissue damage as the tumor outgrows its blood supply or encroaches on blood flow to the area. They may also produce substances that cause cell damage. And then their ability to cause death. Benign tumors don't usually cause death unless, again, its location interferes with vital functions. And malignant tumors usually cause death unless growth can be controlled. All right, how does cancer spread to other parts of the body? So the lymph and blood are the primary ways in which cancer cells spread. Lymphatic spread, which is the transport of tumor cells through the lymphatic circulation, is the most common. Tumor emboli enter the lymph channels by way of interstitial fluid, which communicates with the lymphatic fluid. Malignant cells also may penetrate lymphatic vessels by invasion. After entering the lymphatic circulation, malignant cells either lodge in the lymph nodes or pass between the lymphatic and venous circulations. Tumors in areas of the body with rapid and extensive lymphatic circulation are at high risk for metastasis through lymphatic channels. Breast tumors frequently metastasize in this manner through axillary, clavicular, and thoracic lymph channels. Hematogenous spread, which is the dissemination of malignant cells via the bloodstream, is directly related to how vascular the tumor is. Few malignant cells can survive the turbulence of arterial circulation, insufficient oxygenation, or destruction by the body's immune system. In addition, the structure of most arteries and arterioles is far too secure to permit malignant invasion. Those malignant cells that do survive are able to attach to endothelium and attract fibrin, platelets, and clotting factors to seal themselves from immune system surveillance. The endothelium retracts, allowing the malignant cells to enter the basement membrane and secrete proteolytic enzymes. These enzymes degrade the extracellular matrix, allowing implantation. So this kind of shows you how the cancer cells kind of get into the blood system or the lymph system and spread to different parts of the body. So breast cancer, bone cancer, brain cancer, a lot of times by the time these patients are diagnosed, they already have mets to other parts of the body. So when you think about risk factors, an easy way is to caution. So any change in bowel or bladder habits, a sore throat that doesn't heal, any unusual bleeding or discharge, thickening or lump in the breast, indigestion or difficulty swallowing, these are long-term effects, obvious changes in moles or warts, a nagging cough or hoarseness, and other signs, extreme fatigue, unexplained weight loss, and unexplained pain. So all of these may cue somebody to go in and then they get diagnosed with cancer. So what causes cancer? Pretty much everything. So you have viruses, bacteria, physical factors like sunlight, radiation, chemical agents like tobacco, asbestos, genetic factors, our diet, drugs, pretty much everything. All right, how do we protect our body? There are 3 lines of defense. The first is pretty much to keep everything out. How do we do that? What's our primary line of defense? Through our skin and mucous membranes. The second is our inflammatory response and fever. Our body notices something in there that shouldn't be there, so our fevers are going to try and burn it out. Inflammatory response is going to produce those phagocytic cells that's going to engulf it and get it out of our body. And then we have our immune response, which is going to send out the attackers to invade that foreign object in the body. I'm going to talk about primary and secondary prevention. So primary prevention is concerned with reducing that cancer risk in healthy people. So we're going to educate. We're going to tell our patients to eat a good diet. Don't drink, don't smoke, avoid any known carcinogens. We're getting it out there, reducing that risk. Secondary prevention involves detection, screening to achieve early diagnosis, and intervention. So we're going to identify those people at high risk for cancer. We're going to talk about cancer screening such as self-breast exam, that self-testicular exam, screening colonoscopies, PAP, and HPV test. We're going to get it out there, going to get those detections early so that we can treat and reduce the risk of that cancer spreading throughout the body. Tertiary prevention efforts focus on monitoring for and preventing reoccurrence of the primary cancer, as well as screening for development of second malignancies in cancer survivors. Survivors are assessed for the development of second malignancies such as lymphoma and leukemia. So in diagnosing cancer, we're going to determine the presence and extent of the tumor, identify any possible spread of disease or invasion of other body tissues, evaluate the function of involved and uninvolved body systems and organs, and obtain tissue cells for analysis, including evaluation of tumor stage and grade. Staging determines the size of the tumor, the existence of local invasion, lymph node involvement, and distant metastasis. Several systems exist for classifying the anatomic extent of disease. The tumor, nodes, and metastasis system, which is the TNM system, is one system used to describe many solid tumors. Grading systems seek to define the type of tissue from which the tumor originated and the degree to which the tumor cells retain the functional and histologic characteristics of the tissue of origin. Samples of cells used to establish the tumor grade may be obtained from tissue scrapings, body fluids, secretions, washings, biopsies, or surgical excisions. The grade corresponds with a numeric value ranging from 1 to 4. Grade 1 tumors are also known as well-differentiated tumors, which closely resemble the tissue of origin in structure and function. Tumors that do not clearly resemble the tissue of origin in structure or function are described as poorly differentiated or undifferentiated and are assigned a grade 4. These are some diagnostic tests that we use to diagnose cancer. So we do x-rays. A lot of times, especially with lung cancer, patients come in for some other reason and they get a chest x-ray, and that's how they notice that they have some type of cancer or tumor in the lungs. They do CTs, ultrasounds, MRIs, angiographies, and the diagnosis of cellular types of cancers can be done through tissue samples from biopsies. This is your needle biopsy. They use a fine needle to collect fluid and cells. A core biopsy is used to collect tissue samples. So the core biopsy is going to be a little bit bigger than just your needle biopsy. Direct visualization, so that's your colonoscopies, cystoscopies, bronchoscopies, any of those where they can directly visualize the tumor. Other non-specific tests. A lot of times they see abnormalities in normal blood work, which will trigger them to do further testing to determine what's going on. So you may see an extremely low white blood cell count. Maybe their platelets are out of whack. Your hemoglobin hematocrit are really low. Those electrolytes are out of whack. Liver enzymes, any of those things can lead them to do further testing to determine if a patient has cancer or not. These are some different tumor markers, like your CA-125. If that's elevated, they may suspect ovarian, digestive tract, uterus, cervix, pancreas, liver, colon, breast, and lung cancers. So as you can see, just because they do a CA-125 and it's elevated, that doesn't mean, oh, they have breast cancer, oh, they have ovarian cancer. But it triggers them to do further testing to determine what's going on with those different organs. We talked about a prostate-specific antigen test with our BPH lecture. So when that PSA is elevated, doesn't definitively mean that they have prostate cancer, but it can lead them to a diagnosis of prostate cancer because other things can cause that PSA level to increase. So I'll let you read over these different tumor markers. Treatment options offered to patients with cancer are based on treatment goals for each specific type, stage, and grade of cancer. The range of possible treatment goals includes complete eradication of malignant disease, which would be a cure, prolonged survival and containment of cancer cell growth, control it, or relief of symptoms associated with the disease and improvement of quality of life, which is palliation. Treatment approaches are not initiated until the diagnosis of cancer has been confirmed and staging and grading has been completed. So the patient is diagnosed with cancer, now what? There are many types of cancer treatments. The types of treatment that you will have will depend on the type of cancer that you have and how advanced it is. Some people with cancer will only have one treatment. Most people will have a combination of treatments such as surgery, chemotherapy, and/or radiation therapy. May also have immunotherapy, targeted therapy, or hormone therapy, or stem cell transplant. Surgical removal of the entire cancer remains the ideal and most frequently used treatment method. However, the specific surgical approach may vary for several reasons. Diagnostic surgery, or the biopsy, is the definitive method for obtaining tissue to identify the cellular characteristics that influence all treatment decisions. Surgery may be the primary method of treatment, or it may be prophylactic, which a few years ago, Angelina Jolie is real big in the news. She had bilateral mastectomies to decrease her chances of getting breast cancer. It can be palliative, which can relieve symptoms, or it can be reconstructive. About 60% of patients with cancer receive radiation therapy at some point during treatment. So radiation is the treatment of choice for some tumors to kill or reduce the tumor size, relieve pain, or to relieve obstruction. Radiation therapy, again, can be used for curative reasons, control, or palliative. You have external and internal radiation. So external is where they go to the radiation room, they lay on a table, and they focus the radiation externally. Internal radiation, they can put seeds into the bladder, into the prostates. That's internal radiation. And if they are in a home setting, we have to make sure that the family members or whoever's in that setting with them knows how to do radiation prevention, radiation precautions, because they are radioactive and we don't want to transmit that to people who don't need it. We need to monitor their effect on the GI system, the effects on the bone marrow, other systemic effects, and any long-term effects or tissue changes. So typically, if they're doing external radiation, you got to think about the area where they're getting radiation because they can start having symptoms around that area. So if they're getting radiation to their lung, you may notice GI problems. If they're getting radiation to the head, you may notice some mental changes and things like that. So you have to think about what's surrounding that area that may be affected, where you may see changes. So treatment schedules are planned according to radiosensitivity of the tumor and tolerance of the patient. I had a patient one time who was in so much pain he could not lay down flat long enough to get his radiation treatment, so they kept trying to figure out how to medicate him. We never could really get enough medication for him to lay there and be still for this radiation procedure, so he did miss a few radiation treatments. It's kind of like if you can endure it, it's going to help and decrease that pain later on, but you have to be able to get through the radiation treatments at that time. We're also watching their blood cell counts, because if everything drops too low, they may not be healthy enough or up to different radiation therapies. Some side effects, again, like I was talking earlier, you have to think about surrounding areas. If they're doing external, you got to look at the skin. They may have some sloughing, some redness, the irritation on the skin may affect their mucous membranes, again, the GI tract, and they may get something what's called radiation pneumonia, which is very similar to pneumonia, but it's damage within the lungs. So what are some nursing considerations that we have to think of with radiation therapy? Patient and family education, any restrictions that they have, any precautions, skin care, mouth care, and protection of their care providers. Chemotherapy involves the use of antineoplastic drugs in an attempt to destroy cancer cells by interfering with the cellular functions, including replication and DNA repair. Chemo is used primarily to treat systemic disease rather than localized lesions that are amenable to surgery or radiation. Chemo may be combined with surgery, radiation, or both to reduce the tumor size preoperatively, to destroy any remaining tumor cells postoperatively, or to treat some forms of leukemia or lymphoma. The goals of chemo must be realistic because they will determine the medications that are used and the aggressiveness of the treatment plan. So combination therapy with chemo and surgery and or radiation prevents resistance. So you have your adjuvant therapy, which is used postoperatively to destroy any of those remaining tumor cells, and then you have your neoadjuvant therapy, which is usually given before surgery to reduce that tumor size. Chemotherapy targets cells that divide rapidly. That's going to be your hair cells, mucosa, bone marrow, and your skin cells. So that's where you're going to see a lot of your side effects. So that's why many people, as you see, will lose their hair during chemotherapy treatments. They will get sores in their mouth. We have to educate them with that. Those sores in the mouth, it goes down the entire GI tract. They are having nausea, vomiting, diarrhea. They may have skin infections. They're at high risk for skin breakdown, all of those things. Chemotherapy cannot distinguish between normal cells and cancer cells. So with our lab work, we're seeing decreased white blood cells, which increases their risk for infection, decreased platelets, increases their risk for bleeding, and a lot of times you'll see a low hemoglobin and hematocrit as well. So side effects may be drug specific. For example, your anthracyclines, you see increase your chance for cardiotoxicity. Vinca alloys increase the risk for neuropathy and constipation, and bleomycin, you see an increased risk for pulmonary fibrosis. The severity of side effects varies between drugs. So just because they're targeting these highly dividing cells, some may cause you to lose your hair a lot quicker or more often than some of the other drugs. Your side effects are often seen 7 to 14 days post-treatment. So when we're looking at lab work, usually about 7 to 14 days is when they're going to hit that nadir period. So that nadir period is when everything is at its lowest. It's when they're at the highest risk for infection and complications. So when administering chemotherapy, we have to pay attention to the dosage. Do we have an appropriate dosage? We have to watch for extravasation because we do not want that chemo medication getting outside the vein because it can cause tissue damage. If that happens, we need to make sure that we try to get as much of that chemotherapy out of the skin as possible. We may have to administer an antidote, and we're watching for hypersensitivity reactions. Each time a tumor is exposed to chemotherapy, a percentage of the tumor cells are destroyed. Repeated doses of chemo are necessary over a prolonged period to achieve regression of the tumor. Eradication of 100% of the tumor is almost impossible. The goal of treatment is eradication of enough of the tumor so that the remaining malignant cells can be destroyed by the body's immune system. Actively proliferating cells within a tumor are the most sensitive to chemotherapy. Non-dividing cells capable of future proliferation are the least sensitive to antineoplastic medications and consequently are potentially dangerous. However, the non-dividing cells must be destroyed to eradicate the disease. Repeated cycles of chemotherapy or sequencing of multiple chemotherapeutic agents are used to achieve more tumor cell destruction by destroying the non-dividing cells as they begin active cell division. So anybody administering chemotherapy has to be trained on giving chemotherapy. Safe handling is essential. Chemotherapy are cytotoxic drugs and are carcinogenic, mutagenic, and teratogenic. Potential exposure occurs during preparation, administration, and handling of the lines, body fluids, the bags, all of those things. We always need to take universal precautions. So if somebody's administering chemotherapy, you should see them with a gown, gloves, a face mask, shield, all of that to prevent any exposure. So we should be able to assess and manage the toxic effects of drugs. We need to report any to the physician, any side effects. We need to manage nausea and vomiting, inflammation, ulceration of the mucous membranes, hair loss, anorexia, monitoring the lab results, and holding the chemotherapy if the blood counts are seriously low, administering any blood or platelets, assessing for dehydration, teaching on fatigue, immunosuppression precautions, and providing emotional and spiritual support to patients and families. Cancer patients may go through anxiety, may have disturbed body image, a fear of rejection, and anticipatory grieving. They're at high risk for infection. They may be at risk for injury, maybe altered nutrition and impaired tissue integrity. So impaired skin integrity, they're at high risk for problems with the skin. We don't want to use any harsh soaps, perfumes, lotions, powders, deodorants, anything that's going to harm the skin. Making sure that we don't use too hot of a water to scald our skin, avoiding any rubbing or scratching, not using straight edged razors, using the electric razors. Avoid applying hot water bottles, heating pads, ice, excessive tape to area. Avoid exposing the area to sunlight or extreme cold weather, and educating on applying vitamin A and D ointment to the area. So we're going to protect our skin and teach our patients how to do that. This is an example of grade 4 mucositis. So like we talked about, those rapidly dividing cells, these patients can get extreme sores in the mouth like this. We want to tell them to avoid the alcohol in the mouthwash, using a soft bristled toothbrush, and protecting our mouth so we don't end up like this. Again, we talked about alopecia, making sure that our patients are aware that they may have some hair loss, getting them set up to go ahead and order wigs. Do that before they start losing their hair so that they can match their color appropriately. And many times after they lose their hair, it may grow back a different color. It may grow back a different texture. They may have curly hair as opposed to the straight hair that they used to have. Nausea and vomiting is a big one, so we need to make sure that we're giving appropriate medications along with our chemotherapy meds to prevent nausea and vomiting. Talk to them about distraction. avoiding those unpleasant sights, odors, anything that triggers this, and making sure that they keep up with their nausea medication after chemotherapy so that they don't experience any nausea or vomiting. We need to make sure that they remain hydrated, making sure that they know to drink plenty of water during treatments, between treatments, staying away from caffeine. They can have caffeine, but make sure that they drink plenty of water to counteract that caffeine. Encouraging frequent oral hygiene, providing pain relief. We may have to sit them down with a dietitian and order, if they're not eating, making sure that they get nutritional drinks or supplements to help them get through their treatments until they're able to eat and tolerate food again. So we need to monitor and manage potential complications: tumor lysis syndrome, infection, septic shock, bleeding, and hemorrhage. Tumor lysis syndrome is an oncologic emergency which occurs due to rapid cell lysis or death and large amounts of cell metabolites in blood. If untreated, it can lead to acute renal failure, cardiac arrest, and death. We see a lot of infection with our neutropenic patients, and so neutropenia is an abnormally low ANC, which is an absolute neutrophil count. The risk of infection rises as the ANC decreases. As the ANC declines below 1500, the risk of infection rises. An ANC less than 500 reflects a severe infection. At this point, the patient is neutropenic. Nadir, which is the lowest ANC after myelosuppressive chemotherapy, targeted therapy, or radiation therapy that suppresses the bone marrow function. Factors that contribute to infection, as you can see here: impaired skin and mucous membrane integrity, chemoradiation, malignancy, malnutrition, IV catheters, invasive procedures, age, chronic illness. All these things contribute to infection. Septic shock is a complication that we must prevent or detect early and treated quickly because it could lead to ICU, and they can have a lot more complications after that, even death. Patients who are neutropenic or who have hematologic malignancies are at our greatest risk. Signs and symptoms include, you may notice early altered mental status, either a subnormal or elevated temperature. It doesn't always have to be elevated. Cool and clammy skin, decreased urine output, low blood pressure, high heart rate, may notice some dysrhythmias, electrolyte imbalances, tachypnea, and abnormal ABGs. So as we know, platelets are essential for normal blood clotting and coagulation. Thrombocytopenia, which is a decrease in the circulating platelet count, is the most common cause of bleeding in patients with cancer and is usually defined as a platelet count less than 100. The risk of bleeding increases when the platelet count decreases between 20 to 50,000. A platelet count lower than 20 is associated with an increased risk for spontaneous bleeding. Most patients with a platelet count in this range require a platelet transfusion. Thrombocytopenia often results from bone marrow depression after certain types of chemo and radiation therapy and with tumor infiltration of the bone marrow. In some cases, platelet destruction is associated with an enlarged spleen and abnormal antibody functions, which occur with leukemia and lymphoma.